All right. Uh, Everybody can see now.
Yes, sir.
All right. So tuberculosis, yes, that's what I was talking about. So tuberculosis is something which we are supposed to get rid by the next year. This is what I was telling you. So that is why I don't know how much this topic will be relevant after next year, but chalo, this year, so definitely it will be relevant. So you should be happy. You should be happy about it. So if I talk about this anti-tubercular drug, first of all, what is tuberculosis? What happens when there is tuberculosis? So first thing is, see, there will be, like, this is basically the a basic idea, very basic idea. First what happens is that there will be some airborne droplets. Okay, like suppose somebody sneezed, some TB patient sneezed, some TB patient coughed. Okay, so if that happens, then you will see that there will be some airborne droplets. There will be some airborne droplets, and let's suppose a healthy individual takes that. Okay, there will be a lot of people who has got a bad habit of spitting roadside, isn't it? In India, this is very common that people spits roadside. Though we are right now on, like, doing a lot to control it, but people do that. So that is very bad, because when you are going to spit and you don't know whether you are having the TB bacteria in yourself or not. So if there is a tuberculosis bacteria, then even through that, there it can spread. Okay, like maybe you will see that you are using, or you are riding a bicycle, and in front of you there is a autowala who spits and goes away, and wherever the autowala spits, your bicycle comes up over there, within some few minutes or seconds. Then maybe, from there also you can get it. So these are very bad habits, or these are very bad things. So why? Because you are going to inhale it. So once you inhale that thing, then definitely you will see that the bacteria will enter in your respiratory system. So this is where the game begins, when bacteria enters into the respiratory system. Now, next what will happen is that there will be something called as initial infection. So when does initial infection start? When the bacteria is inside your alveoli. Now what happens? Inside your alveoli, there will be lot of macrophage. Okay, do you know, like, in various organs we have a lot of macrophages. Like, similarly there are some alveolar macrophage also. Maybe you must have read nervous system, central nervous system, microglia, liver, the Kupffer cells. Then your kidney has the mesangial cells. Similarly, have you heard of these things? Skin has Langerhans cells. So similarly, you will see that in your lungs there are present these macrophages. They are called as the alveolar macrophages. Now, the problem here is that when macrophage engulfs them, the problem with this bacteria is that this bacteria can survive within the macrophage. That is the big problem. So what happens, like, if you look at the picture over here in front of you, so you see that there is this bacteria which has gone inside some of these macrophages, and they have, in this way, they have actually evaded the immune response. But later on what happens is, see, what do you think? This is an acute case or a chronic case? Tuberculosis, here we see these are all chronic cases. Okay, tuberculosis is a chronic case. Do you know there is like, in medicine there are two things. One is called as acute, another one is called as chronic. What do you mean by acute? Lack of cuteness? Definitely no. Acute means short duration. Okay, we classify, in medicine we classify diseases on the basis of duration also. So as far as short duration diseases are concerned, they are called as acute, and as far as long duration diseases are concerned, that is called as chronic. There are lots of debates among the general medicine practitioners that what should be the criteria for acute, but normally what people say is like 6 months is the category. Okay, normally, like, if something happens within 6 months, so that's acute. If something happens for more than 6 months, that is chronic. But again, there will be a huge amount of argument on this. So basically there is no such there are lots of debates, so there is nothing fixed about it. Okay, so but the point is this: if something happens, like, let's take some easy example. Let's say you ate some bad food, spoiled food, and you developed food poisoning. So that's acute. It happens immediately. But if we talk about this tuberculosis, if we talk about leprosy, this takes a lot of time to happen. So these are all chronic diseases. Okay. So now what happens is that the organism resides within the macrophage. Now slowly and gradually what will happen, that the immune system will start to recognize. So how long will you hide? So sooner or later you will be recognized. So body's immune system will recognize the presence of Mycobacterium tuberculosis, and what will they do? It will try to hold it over there, restrict it over there. And then what will happen? These infected macrophage, along with other immune cells, say for example primarily the immune cell that works here is the T cells. So the T lymphocytes, they will aggregate over here. So infected macrophage and T lymphocytes, they will all aggregate over there and a lump will form. Okay? Like you will see that in the picture, that there is a spherical structure is formed. This at the bottom side of the bottom part of the slide. So this spherical structure, that is called as granuloma. Okay. So infected macrophage, they are going to surround, they will cordon, like suppose there is a somewhere you see that there is some terrorist activity going on. So what will happen? There will be a lot of police coming up over there, okay, military coming up over there, and they will surround that area. So when they will surround that area, we will call that as that entire area as granuloma. Okay. So when somebody says what is a granuloma, so we say that granulomas are organized immune structures that attempt to wall off and control the infection. Okay, I'll repeat, it's worth repeating. So what is a granuloma? So granulomas are organized immune structures that attempt to wall off, you understand, like throw away or like keep off, keep them stay away, keep them away.
স্যার বলছি লাইক প্যাথোজেনের সারাউন্ডিং করছে, মানে হোয়াইট ব্লাড সেলস এন্ড অল ওইগুলো মানে ওই ল্যাঙ্গারহ্যান্স টাইপের সেলস।
কারেক্ট, alveolar macrophage, ল্যাঙ্গারহ্যান্স তো স্কিনে থাকে, দিস ইজ নট, দিস ইজ ইন দ্য alveoli. Yes, ঠিক আছে। তো granulomas are organized immune structures that attempt to wall off and control the infection. So this is the first thing that will happen, that is granuloma formation. After that what happens is, it is called as LTBI. What is LTBI? LTBI is latent TB infection. TB is the short form of tuberculosis. I hope you know this. So latent TB infection. So in many cases the immune response effectively controls the infection, and if that happens then the bacteria will become dormant. So I hope everybody knows dormant. Dormancy means sleepy, they go to sleep, they fall asleep. So if it goes dormant, then we call it as latent TB infection. Now a person with latent TB infection does not exhibit symptoms and is not contagious, but the bacteria remain alive in the body. Okay, so because it's dormant, na? So if you are going to go for any tests, okay, lab investigations, diagnostic test, anything like that, so like you will see that there is presence of the organism inside the body, but patient is absolutely fine, no symptoms are there, and from this patient it won't spread also. Okay. Now someday later, whenever you will be developing any kind of weakness related to immune system, immune weakness, it can be a simple case, say you are taking an immunosuppressant drug, simple case like steroid, you are taking steroids, or there is malnourishment, and very obvious cause is HIV. HIV, human immunodeficiency virus, which causes AIDS disease, so that HIV. So all these conditions, so what did I say, let's count it out. First, medications like corticosteroids, number 2 malnutrition, number 3 HIV infection. All these cases, they weaken the immune system, and that reactivates LTBI or latent tuberculosis infection, and your latent disease now becomes an active disease. So what is the difference between an active TB and a latent TB? So latent TB, it was non-contagious and no symptom is there. In active TB, the bacteria will multiply, and now the person will become not only symptomatic but also contagious. Are you getting it? So this is the moment when the person will not only become contagious, but also the person will become symptomatic. Both things will return back. Now the most common thing in tuberculosis that we all learn, and in the picture also I have shown, that is related to lungs. Now when it is related to lungs, we call it as pulmonary TB, pulmonary tuberculosis. And why primarily we talk about this? Because this is the primary site for infection. Primary site of infection is the lungs. So that is why pulmonary TB. Mainly when TB occurs, you will see people are coughing out blood, coughing out sputum. Well, it's all related to the lungs, but not respiratory system. But it is not that everything is completely related to the respiratory system. It is not like that. But and I will teach you also, because see, we are not discussing medicine here, but also I am trying to help you out with a little amount of pathology also. I think this is there in your pathology as far as I know, and this whatever I am teaching you, this will not only help you in pharmacology, but it will help you in pathology as well. You can use this same same whatever I am teaching you, you can use it for your pathology examination or something like that. So I think you will be learning. You have TB in your syllabus somewhere.
Yes, sir. Yes.
Yes. Yeah. So that is why I have made it a compact topic where I will not only teach you the pharmacology, but also I will help you with the disease as well. And remember, if you keep these notes, this will be helpful for you in general medicine also next year. So okay, so understand it thoroughly. TB. So as I was talking about it, so you see, first infection comes up in the lungs for tuberculosis. That is why in pulmonary tuberculosis, primary site of infection is lungs. Now suppose infection progresses. So what will happen? All sorts of symptoms will come up which are related to your lungs. Suppose you develop pneumonia. Pneumonia is a disease related to lungs. So what do you see? If you have pneumonia, difficulty in breathing you will get cough, you will get fever. So see, here also it is happening. So some specificity is there because it is mycobacterium species. So some specificity is there, that there is night sweats. Okay, there will be night sweats. This is something that you should remember. Night sweats will be there. Weight loss will be there, and patient can also cough up blood. What is the technical name? Anybody knows when a patient actually coughs out blood or coughs up blood? What is it scientifically or medically? What do we call it? Anyone has any idea? Similar to?
Say hemoptysis.
Very good. Yes, of course. It is called as hemoptysis. The word is hemoptysis. Very good.
Okay.
Hemoptysis. HAEMOPTYSIS. Hemoptysis.
Yes, sir.
Definitely. Everybody should be very careful about this, because today what we are learning is not only pharma, but this will be helpful in pathology also and general medicine also. Everybody it will be helpful. So it is, yes, hemoptysis. Hemoptysis is coughing up of blood. So there will be cough, there will be fever, night sweats, and weight loss. Weight loss, so it is a very common thing for any chronic disease. So here also that will be definitely helpful. And now remember that bacteria can damage the lung tissue and lead to cavities in the lungs. Now, do you understand how dangerous this is? So it is dangerous for anybody, because you understand, it's not a cavity in your tooth, it is cavity in your lungs. So this is called as, these are the things that happens in pulmonary tuberculosis. Now in some cases it spreads to other parts of the body, like I told you in the beginning, that sometimes it spread to other part of the body through bloodstream or lymphatic system. Actually there is no other way. Either it can spread through blood or it can spread through lymph. So where can it go? It can go to the brain, it can go to bones, it can go to kidney, it can go to lymph node. ठीक है ना? Understood? So brain, bones, kidneys or lymph node. हाँ. So what do we call it? It is called as disseminated tuberculosis, or you can also call it as extrapulmonary tuberculosis. Either you can call it disseminated tuberculosis or you can call it extrapulmonary tuberculosis. Okay, are you getting the word? I mean disseminated tuberculosis or extrapulmonary tuberculosis. See whether you understand or not. Extra doesn't mean like you have 1 plus 1. Extra here means outside. Intra means inside, extra means outside. So outside pulmonary, extra pulmonary. Disseminated means diffused, it is spread out in different parts. So that is disseminated. ठीक है?
Yes, sir.
স্যার ওটাকেও কি মানে যেগুলোতে যাচ্ছে মাইগ্রেট করছে সেখানে কি ক্যাভিটিস করে দেয়?
হ্যাঁ, exactly.
আচ্ছা।
So okay, so see what happened till now. What are the steps that we learned? So first thing we learned that there was infection and transmission. है ना? This is, all of you remember, I guess, there is infection and transmission. Where somebody spits, you inhale. Okay, somebody coughs, you inhale, droplets go in. Then we learned the initial infection, that is when the macrophage is going to engulf it and it is going to survive over there. That is the initial infection. After initial infection, what we learned? Granuloma formation, because now there are some T lymphocytes and the macrophages, they will be cordoning that area, surrounding that area to wall off the infection. Then what did we learn? We learned that there is latent TB infection. Okay, so latent TB infection is LTBI. And after that what we learned? We learned reactivation. Remember? Reactivation and active tuberculosis. Now after that what we learned? That is pulmonary TB, pulmonary TB, and sometimes in some cases mycobacterium can spread into other parts, that is disseminated, or what else I said? Extrapulmonary. Okay?
Yes, sir.
Right. So what
extrapulmonary টা কি রেয়ার না অ্যাডভান্সড কেসেসে এটা হয়?
No, advanced cases, not rare.
আচ্ছা, ওকে স্যার।
হ্যাঁ, so you wanted to I'll tell you later on. So you see, this is the immune response. So if somebody asks you what are the immune cells which are responsible here, so you have to say T cells are responsible, B cells are responsible, and macrophages are responsible. Now over time this response can lead to tissue damage and formation of scar, okay, within the granuloma. So within those granuloma there can be scar tissue also forming. Okay, scar tissue formation can take place over there. Clear?
Yes, sir.
Yes, sir.
All right. So now next thing is what you need to know, that is about the okay. So everybody has understood this part. Who are the population who are vulnerable? HIV, close contact, congregate settings, healthcare workers. Huh?
So children, মানে বাচ্চারাও?
হ্যাঁ, definitely. Children if they are under 5 years old. Migrants and refugees, elderly due to weak immune system, then people who are drug abusers, okay, those people who have got CKD, chronic kidney diseases, okay, or diabetes, or if there are some people who are like poverty stricken, homelessness, then tobacco smokers because their lungs are already compromised. So all these people, they are going to suffer from all these things. Now, as far as the, if we talk about the, drug resistance. So as far as the drug resistance is concerned, there are like they develop resistance to the antibiotics. We have got actually a lot of cases where we have seen that normal drugs don't work out here. But how do we do the diagnosis? Normally, for diagnosis, we can go for sputum culture, we can go for chest X-ray, or we can go for the molecular tests. Okay, so these are the things that can be done. So diagnosis is clear to all of you?
Yes, sir.
Yes, sir.
Okay. Now next thing that we will discuss, that is about the treatment. How to do the treatment. I hope lab investigation is clear to all of you. That is called as Mantox test. Tuberculin is the purified protein from Mycobacterium, which is introduced subdermally, and we check the measurement of the wheal. I hope you know what is wheal, the red circular patch. So we try to check out the wheal, and accordingly we decide whether it is Manto positive or Manto negative. Now coming to the real pharmacology lecture. So over here we need to talk about the anti-tubercular drug. So first line anti-tubercular drug. What is first line tell?
বলছি wheel বলতে কি ইনফ্ল্যামেশন এর যে প্লেয়ার হুইল ওগুলো?
হ্যাঁ, ওইগুলোই।
আচ্ছা, ওকে স্যার।
Okay, হ্যাঁ, তো yes. So when we talk about the first line anti-tubercular drug, remember these drugs are most effective and commonly used for TB treatment. Okay, now most effective. So if you are going for first line, like if you are going for any TB treatment, so it is always that you directly go with the first line, because first line is the most effective. Unless and until otherwise indicated, first line is most effective. If you want to use some other drugs also, you have to use it with the first line only combination. Like you can see there is a thing called as INH, isoniazid. It has got a single letter abbreviation also, that is H. Easy to remember is that HRZE. This is how we used to remember, HRZE. And streptomycin is also there. So you can remember it in this way, that HERSZ. Like if you have got anybody whose name starts with S and Z, do you know anybody who's or you can say, like, suppose there is a girl who owns a Suzuki bike or a scooty, so you can say that her Suzuki. So HER Suzuki has S and Z. So isoniazid, that is H, ethambutol will be E, rifampin will be R, and then Suzuki, S se streptomycin, and Z se pyrazinamide. Okay, so if you talk about isoniazid, now there is a small picture I have given. I think it is visible also properly. Now in that picture you can easily understand that which drug works in what mechanism. So in one picture, if all the drug comes up, then it will be easier for you to remember. So that is why I placed this picture. So if we talk about isoniazid, let's start with isoniazid. Where is isoniazid? So if you look at the cell wall synthesis inhibitors on the upper left hand side of the diagram, so you will see that there is example is isoniazid, cycloserine, ethambutol, and all these things. So isoniazid is inhibiting the synthesis of mycolic acid. You know, Mycobacterium tuberculosis, the cell wall has something called as a mycolic acid, and isoniazid, of course it is a cell wall inhibitor, but it is specifically blocking the synthesis of mycolic acid. Okay, so it's the key component of the first line therapy. Understood? Moving on to
Yes, sir.
So moving on to rifampin. Now where is rifampin? If you see on the lower side, RNA polymerase inhibitor, there you will find rifampin. R se rifampin, R se RNA polymerase inhibitor. So rifampin inhibits RNA synthesis in bacteria. by binding to RNA polymerase enzyme. Okay, so if suppose it binds to RNA polymerase enzyme, then do you think RNA polymerase can actually work? If it already binds to RNA polymerase enzyme, do you think RNA polymerase will actually work?
No, sir.
No. So remember this, that RNA polymerase is going to get blocked and there will be no RNA produced over there. Next comes of ethambutol. Now where is ethambutol, how it is working? So if you observe this part, the cell wall synthesis inhibitor, again upper left I think. So again inhibits the synthesis of cell wall. See, this is okay, blocking the synthesis of cell wall, but the first one, isoniazid, that was also blocking the synthesis of cell wall. Category is same, but isoniazid is special because it is damaging the mycolic acid, because of which mycobacterium is special. It got its name from mycolic acid. Happening? Everybody understanding?
না স্যার
না
হ্যাঁ স্যার আমি বুঝতে পারিনি
আচ্ছা, okay. So do you know what is mycolic acid? That's a basic funda. What is mycolic acid? You got any idea?
না স্যার
Okay. Anyone has got any idea about the mycolics?
ব্যাকটেরিয়াল সেল ওয়ালে যে অ্যাসিড গুলো পাওয়া যায়, মানে ফ্যাটি অ্যাসিড টাইপ।
কার কোন সেল বলে?
ব্যাকটেরিয়াল সেল ওয়ালে,
ব্যাকটেরিয়াল সেল বলে।
ওই
আচ্ছা,
মাইক্রোব্যাকটেরিয়াম আর কি।
হ্যাঁ, মাইকোব্যাকটেরিয়াম সেল বল। ওকে,
হ্যাঁ,
তো মাইকোব্যাকটেরিয়াম সেল বলে, হ্যাঁ, কি হয় ওয়ান্স अगेन প্লিজ?
স্যার ওই ফ্যাটি অ্যাসিড টাইপ অফ, মানে কি বলবো, কি বল, অ্যান্টিজেন টাইপ অফ কিছু কি স্যার?
হ্যাঁ, অ্যান্টিজেন তো অফকোর্স দেয়ার ক্যান বি লটস অফ অ্যান্টিজেন, বাট কি, দ্যাট ইজ দ্য কোয়েশ্চেন।
বোধহয় ফ্যাটি অ্যাসিড টাইপের কিছু একটা ছিল।
ফ্যাটি অ্যাসিড টাইপের মানে, ওকে, বাট where is it located? What is it and where is it located?
ওটাই তো বলছি, সেল ওয়ালে কি লোকেটেড?
Cell wall, of course, located. That's it. I'll show you. I'll give you idea. See, suppose basic thing. We will start with the basic thing. What is the basic thing? Basic thing is that there will be like what is this, phospholipid bilayer, because that's quite obvious, huh? It has got a cell membrane, and cell membrane will be made up of phospholipid bilayer. This is easy, and I hope it looks also like some phospholipid bilayer.
হ্যাঁ স্যার।
Acha. So if this is a phospholipid bilayer, now you will see that here there will be present some stick like structures like this. What is this? Have you heard of a sugar called as Mannan sugar?
হ্যাঁ স্যার।
হ্যাঁ, তো remember this is lipoarabino mannan. Lipoarabino mannan. Now, have you heard of something called as peptidoglycan?
হ্যাঁ স্যার।
Thank God.
ব্যাকটেরিয়াল সেল ওয়ালেই তো পাওয়া যায়।
হ্যাঁ, composed of
এনঅ্যাসিটাইল গ্লুকোজামাইন
only
আর এনঅ্যাসিটাইল মিউরামিক অ্যাসিড।
acha. Everybody agrees on this?
হ্যাঁ স্যার
So there will be NAG
হ্যাঁ
and
স্যার
Yeah. So there will be NAG and NAM, and they all will be having crosslinks. Crosslinks is also there, na? That is how they are joined together. Otherwise, they will fall down.
Yes, sir.
Now, above this or outer to this, there will be present a large number of proteins. It's not protein, I'm sorry. These are arabinogalactan. Like this, okay? This is arabinogalactan. I hope you are getting my handwriting.
Yes, sir.
Now,
Yes, sir.
okay. Now, above this arabinogalactan, you will find that there are some sort of these mycolic acids. These are called as mycolic acid, and out of this mycolic acid lies mycosides. So this is basically the structure of a Mycobacterium tuberculosis.
সেই হাতের মতো অ্যান্টিবডি রিসিভ করার মতো করে।
হ্যাঁ,
হ্যাঁ স্যার।
okay. Understood everyone? What is mycolic acid? Those with that clear?
Yes, sir.
হ্যাঁ স্যার, হ্যাঁ হ্যাঁ।
Acha. So that's the thing. So that is what we are discussing. That if we talk about this, what do you say? This isoniazid. The isoniazid inhibits mycolic acid formation. Okay, so it has got the job with mycolic acid. Now, as far as pyrazinamide is concerned, pyrazinamide always works in acidic environment. Okay, and where do you get acidic environment? If there is tuberculosis infected cell, then there will be, the environment will be acidic. Okay, if there is, sorry, if there is TB infected cell, then it will be acidic, and if it is acidic, pyrazinamide will work. Now, how pyrazinamide works, that is still not properly understood as per the literature. Okay, so this is about the first line of drug. So although all the drugs are clear,
Yes, sir.
coming to the second line anti-tubercular drugs. Now these drugs, what are second line? These are drugs which are used when first line medications are ineffective. That means the TB is resistant to the first line medications. Or suppose something untoward incidents happens, like patient had medicine, allergy starts up. Okay, so if the patient cannot tolerate first line, so two things: either the patient is not tolerant to the drug, or the bacteria is excessively tolerant to the drug. So if bacteria becomes too much comfortable with the drug, and if you are not at all comfortable with the drug, in these two cases we will see that there is use of the second line of drug. So in this, first thing is, see, fluoroquinolone. Acha, let's start with ethionamide. So ethionamide, you see, it is working as the cell wall inhibitor once again. Okay, then you will also see that there is like another one which is similar to ethionamide, that is prothionamide. Similarly, you will also see that cycloserine is also present. Do you see all are grouped under cell wall inhibitors?
Yes, sir.
Yes.
স্যার বলছি একটা জিনিস,
হ্যাঁ।
সেকেন্ড লাইন অফ ড্রাগস মানে সেল ওয়াল তো ইনহিবিট করছে এরা, তাহলে তো এদের মানে কি বলবো, এরা একা ইউজ করলেই তো হলো, মানে ফার্স্ট লাইন অফ ড্রাগস এর সঙ্গে কেন ইউজ করতে হয়?
ওই যে বললাম যে if the first line drugs are well tolerated by bacteria, মানে if there is resistance strain to first line of drug,
না স্যার বলছি শুধু সেকেন্ড লাইন অফ ড্রাগসটা ইউজ করলে কেন মানে ইউজ করলে কেমন হয়?
Ineffective. Most effectives are isoniazid, rifampin, pyrazinamide, ethambutol. Most effective.
আচ্ছা বাট স্যার ওটা তো সেল ওয়ালটা ইনহিবিট করছে এমনি তো মরে যাওয়ার কথা
Yeah, but like every organism is different. Organisms are susceptible to different drugs. এটা তো true.
ও হ্যাঁ হ্যাঁ এটা ঠিক
অ্যান্টিবায়োটিকের ক্ষেত্রে there is always something called as a drug of choice.
হ্যাঁ স্যার
Right. Okay. So here most important discussion is that you have already studied. That is fluoroquinolone. So drugs like levofloxacin, moxifloxacin, they are used as alternative to first line drug. But if you think that no, you are going injection, you are going to play injection, then you can inject amikacin, kanamycin, capreomycin. Okay, so these injectables are primarily used when the TB is drug resistant TB. Because you see levofloxacin, moxifloxacin, gatifloxacin, they are all DNA gyrase inhibitors. Once again in that diagram you will be able to see. Okay, can you see the diagram?
হ্যাঁ স্যার
All right. So this is the idea, and okay, so these are typically used in cases of drug resistant tuberculosis. Now there are some other drugs like ethionamide, cycloserine, PS, para-amino. Have you seen PS, para-amino salicylic acid? One, two, three, four, five. In fifth number it is written, second line. Para-amino salicylic acid.
স্যার এটা মানে এটা কিসের মানে
Drug. Again, these are all second line drugs. So you have got second line drugs as levofloxacin, moxifloxacin, gatifloxacin. You can also have drugs like ethionamide, cycloserine, PS. Now if you think that there is development, there has already there is development of drug resistant tuberculosis, then you should always go with the injectables. What are injectables? Like we have got kanamycin, we have got amikacin, we have got capreomycin. Okay, these are all injectables. Okay.
ওকে স্যার
Now also remember that we can also go with the combination therapy as well. So we can use a lot of combination therapy. There are a lot of new drugs that has come up. Okay, so this combination therapy is very much possible. So out of these first line drugs, let us talk about isoniazid a little bit. So what did we learn till now? Till now we have learned that isoniazid is going to prevent what formation? Mycolic acid formation. So if mycolic acid does not form, see rest of the cell wall remains over there. Only mycolic acid is missing. So what will happen? Rest everything is there, only mycolic acid is missing. Anybody has any microbiological idea that if there is everything missing, only mycolic acid is, everything is intact, only mycolic acid is missing, what should happen? Any guesswork? No?
ঠিক বুঝতে পারছি না এটা
Okay. Rest? Anyone?
না স্যার
Awesome.
না স্যার
All right. So remember, if mycolic acid is not present, then your immune system, see, problem was to hide from immune system, na? If mycolic acid is not present, it will not be able to hide from immune system. It will be more susceptible to immune system, it will be more susceptible to other anti-tubercular drugs. So now if you are giving it in combination, then one will make it intolerant to anti-tubercular and the other anti-tubercular will kill it. Then comes up see, it is making the bacteria susceptible to anti-tubercular drugs, and it is making the bacteria susceptible to immune system. First of all, immune system will beat the bacteria. Bacteria is exposed now. Mycolic acid was like an invisible cloak. If you are not producing mycolic acid, that means everybody can see you. Immune system can see you. শুধু তোর জন্য না, ইটস ফর এভরিওয়ান?
না, আমি বলছি মেডিসিনটা ওই ব্যাকটেরিয়াটাকে কিল করার জন্য ইজি হয়ে গেল।
ও আচ্ছা আচ্ছা, হ্যাঁ হ্যাঁ, রাইট হ্যাঁ।
হ্যাঁ।
Okay, then comes up role in treatment. So I think you understand that it is highly effective against growing bacteria and also used as a prophylactic agent to prevent TB in individuals who have been exposed to the disease. So if a person thinks that I am exposed, then also this drug can be given, no? Because if considered that the bacteria is there, the bacteria won't grow again because mycolic acid is not getting formed. Immune system will automatically kill it at low doses. Like if there are very low number of bacteria, person is not suffering, only exposed. That means number of bacteria is very less in the body. You just prevent mycolic acid formation, they will automatically die. Hello?
Yes, sir.
Yes, sir.
Alright. Now as far as the dosage is concerned, see, it is very kiddish. Anytime you talk about dose, it depends on age, weight, and all these things, allergy and all. Now, talking about the most important thing is the adverse effect. Peripheral neuropathy. Okay, so peripheral neuropathy is the most common side effect. Now see, I have written over there that you can avoid this peripheral neuropathy if you are giving vitamin B6 supplementation. So see, if you are going to be very good doctors, don't always chipkofy patients with multivitamin. I see tons of general practitioners, anytime there is a mouth ulcer, they will immediately start with multivitamin. Don't do that. Why will you do that? So if you know what vitamin is required, give that vitamin. Okay. So now another side effect is another side effect is hepatotoxicity and GI disturbance. Okay, gastrointestinal disturbance. Isoniazid is clear?
Yes, sir.
Yes, sir.
All right. You see, I have kept it all in a contrast way so that you can compare how is which one different from which one, so that will help you to remember. So as far as the rifampin is concerned, you know the mechanism of action: RNA synthesis prevention. And if RNA is not synthesized, if RNA polymerase enzyme is blocked and RNA is not getting synthesized, then do you think there will be protein synthesis?
No, sir.
No.
না স্যার, হবে না।
So you understand that this is helpful not only in dormant bacteria but also in actively dividing bacteria, because in dormant bacteria also same thing will happen, in actively dividing bacteria also same thing will happen. That means if any patient is suffering from that latent TB, LTBI, if you remember, there also it will work. Dosage too will again vary. And as far as the adverse effects are concerned, see, do you realize that there are two things which are coming again and again: liver and GIT. Other flu-like symptom is written over here, but see, what is very common and easy to remember will be hepatitis and GI inflammation. Okay?
Okay, sir.
হ্যাঁ স্যার।
All right. Similarly, next thing is pyrazinamide. So like I said earlier also, that idea is not very clear, okay, but we know that it works in a acidic environment. So over here, if we talk about this pyrazinamide, you will see that here they are used in the initial phase of TB infection. Okay, they are used in the initial phase of TB infection, and that reduces the bacterial load. And since pyrazinamide's mechanism of action is not known, but one thing we know, that it is active and effective against the dormant bacteria. That means if somebody is talking about LTBI, what are the drugs that we learnt now? One drug was rifampin and the other drug was pyrazinamide, isn't it?
Yes, sir.
All right. So what do you think adverse effects, what is the common adverse effects that we learnt? First one is hepatotoxicity. Now here, instead of GI, here it will be JI, joint inflammation, joint pain. Okay. So first two we learnt GI along with hepatotoxicity. This one is hepatotoxicity with JI. What is JI? Joint. Here there will be joint inflammation. Will you remember it this way?
Yes, sir.
Yes, sir.
Acha.
Yes, sir.
Next comes up ethambutol, and I hope you understand ethambutol again is going to inhibit the synthesis of arabinogalactan. You remember the structure arabinogalactan?
Yes.
So it is going to inhibit the arabinogalactan structure. Now, as far as the role is concerned, so primarily it will work in combination, because one is making it susceptible to immune system. Say isoniazid is making it susceptible to immune system, and then you give ethambutol along with it, so it is going to destroy arabinogalactan. So it's very, it's greatly working, dhasu working. Okay. Now one thing that you have to remember, that is ethambutol.
স্যার অ্যারাবিনোগ্যালাক্টান ডেস্ট্রয় করলে কি হবে?
তুই গেস কর। look at arabinogalactan. এবার ভাব দেখি নিজে, what will happen?
আচ্ছা, মানে ওই সেল ওয়ালটা ডেস্ট্রয় হয়ে যাবে।
এগুলো তো সেল ওয়াল ইনহিবিটর না, everyone.
হ্যাঁ স্যার।
All right. Now, what is special about ethambutol is, ethambutol adverse effect is ophthalmic, optic neuritis. Okay, and optic neuritis can lead to vision impairment. So if you are giving ethambutol, make sure that there is regular eye checkup going on. All right.
Yes, sir.
Yes, sir.
Okay. So we are done with the first line drugs. Now we move on to the second line drug. Second line drug, I have put it in 3 categories here. One is fluoroquinolone, one is injectable, and in other case I have placed those ethionamide, cycloserine, PS, all those things. So categorically, if you do it, if we can do it. So fluoroquinolones mechanism, I hope you remember, inhibit the DNA guidase and topoisomerase 4, and they are like DNA guidase and topoisomerase 4. If not there, do you think there will be any DNA replication taking place?
No, sir.
No.
No, sir.
Yes. So definitely. Now role in treatment. It is a second line drug. So definitely it is used as an alternative to first line, because main thing though is first line. Na? Now if you are using it, then remember it is effective against both actively dividing as well as dormant. Okay, it is working against both. Clear?
Yes, sir.
Acha. So now if you talk about the adverse effects, so you see once again joint pain will come up here. So first line drug we ended with joint pain. Here we can begin with joint pain, so that you remember.
স্যার এটা তো জিআই জেআই দুটোই আছে
হ্যাঁ, GI, yes. And there will be see another thing written tendinitis. So if there is prolonged use, then tendonitis will lead to tendinopathy, and of course peripheral neuropathy. So there is nothing more to discuss in fluoroquinolone. Next comes up the injectables, that is amikacin, kanamycin and capreomycin. So they can be injected. But what do? They are all protein synthesis inhibitor. How? By binding to ribosome. Okay? Amikacin, kanamycin and capreomycin. Do you see what is the common feature? All of the three names have got K in it. K. Amikacin, kanamycin, capreomycin. Everywhere the pronunciation of K is present, isn't it? So these drugs, they will bind to ribosome, and primarily we use it in case of drug resistant TB. Okay, so we use it primarily for drug resistant TB. You have to inject it IM or IV, both are possible. Now as far as adverse effects are concerned, see here in the second line, I think you have to remember the adverse effects. You have to take a little bit of pressure and remember the adverse effects. So here the adverse effects will be kidney damage, hearing loss, injection site pain, just like your tetanus and all. So do you remember that which drug adverse effect was optic neuropathy? No, we just now discussed though, few minutes back. Pyrazinamide.
Pyrazinamide.
And now you see that this is which is the drug where there is hearing problem. So eye problem was there, ear problem is here. Which one had hepatic problem, which one had kidney problems? So you can remember, you can play games in this way so that you remember. Okay, here there is hearing loss, not eye, and here there is kidney damage, not liver. Understanding what I'm saying?
Yes, sir.
Okay.
Yes.
Sir, আরেকবার একটু বলতে কনফিউজিং লাগবে।
Why confusing? See, that is why though I have created the chart in this way in front of you. Look at the fluoroquinolone. There we learned what? GI disturbance and joint inflammation. So I was just trying to play with these knowledge so that things become easy for you. So first thing is that where else have we learned about GI and JI? Do you remember that? That's what I'm asking.
স্যার কি মনে আসছে না।
Who remembers?
স্যার জিআই তো প্রস্টাগ্ল্যান্ডিন NSAID তে হয়েছে, NSAID তে হয়েছে।
আরে just now we discussed না?
ও হ্যাঁ বুঝেছি।
Seen pyrazinamide.
ওকে স্যার।
So pyrazinamide has got GI JI.
স্যার এখানে তো আই প্রবলেম রিফ্যাম্পিনেও আছে।
হ্যাঁ আসে তো আমি জিজ্ঞেস করছিলাম তো আই প্রবলেম হলে রিফ্যাম্পিনে আসবে, বাট ইয়ার প্রবলেম হলে
স্যার ওটা তো তাহলে ইনজেক্টেবল
হ্যাঁ ইনজেক্টেবল। এইভাবে মনে রাখতে বলছি। আচ্ছা, হু এলস ইজ হ্যাভিং কিডনি প্রবলেম? Which drug can cause kidney problem?
So, injectable amikacin.
Correct, injectable. Or which can cause liver problem?
The liver problem to first line drug. So,
সবাই ফার্স্ট লাইন ড্রাগ, ইয়েস। বোঝা গেল?
হ্যাঁ স্যার একটু হলেও ক্লিয়ার হচ্ছে।
ইয়েস, তো এটা এরকমভাবে করলে কি ইউ উইল রিমেম্বার যে তাহলে কোনটা কোনটায় কী ছিল, কোনটা লাইক ইউ উইল নট গেট কনফিউজড, তাই না?
হ্যাঁ স্যার।
হ্যাঁ।
Yes, sir.
তো next comes up that this ethionamide, cycloserine, PS. So of course they are also inhibiting cell wall synthesis, and also they are interfering with bacterial metabolism. Okay, so what is their role? So once again used in combination, and in case you see that there is resistance to other medication, then we use this drug. And as far as the dosage is concerned, so I told you this is a very vague point. I've just kept it just to complete the lecture, but this is not, will ask you this question. This is very faltu question. Dosage so depends, always depends. We have studied it in that general pharmacology. And adverse effects. Now see, this is a different kind of adverse effect. Psychological, creates psychiatric problems. Okay, this is a unique one. It creates psychiatric problem. Seen?
Yes, sir.
Yes, sir.
Yes.
So,
So
psychosis টা কি?
psychosis means in simple language madness, sort of maniac. Simple ভাষায় পাগলাম.
Okay, sir.
Okay. So done. Can we proceed?
Yes, sir.
Achha.
হ্যাঁ স্যার।
So next we talk about the combination therapy. So as far as the combination therapy is concerned, primarily this is for the drug resistant strain, and here we combine multiple second line drug just to increase the effectiveness and reduce the risk of further resistance development. Okay, and also there are some new anti-tubercular drug, novel money new. Okay, so bedaquiline and delamanid. Okay, so these are two novel anti-tubercular drugs, and they are again for the drug resistant TB, and even if second line drugs fail, then these novel anti-tubercular drugs will help us. Okay, so it is like, always remember that treatment of drug resistant TB is very complex and very long lasting. Like it can take 1.5 year. Like you see, it's written 18 months. 18 months means 12 plus 13, 15, 16, 17, 18, 12 plus 6. So 1.5 months. And if there is second line treatment going on, second line drugs are given, so you understand there are so many side effects, so you have to take care of the side effects also. All right.
Yes, sir.
Yes, sir.
All right. So if this part is clear, now let's talk about this portion, that is the treatment regimen. Now I will teach you two types of treatment regimen. So this is a treatment regimen for drug susceptible TB, one a normal TB, like the TB where the bacteria is susceptible to drug. How to treat that case? One is the simplest case. So like I said, HRZE, that's the main formula for treatment of TB, HRZE. So first thing is isoniazid, then rifampin, then ethambutol, and then pyrazinamide. So this is a standard treatment. Now as far as isoniazid and all of these drugs are concerned, they are what, injectable or oral? So as you can see, it's written they are all oral. Now how is treatment done? So remember, there are basically two phases of treatment. If treatment is done phase wise, there is an initial phase and then there is a continuation phase. So initial phase is a 2-month phase, and during these 2 months all the 4 drugs are given, all the 4. Now after this 2 months are over, then the patient is given only with isoniazid and rifampicin. So, do you realize what is the role of rifampicin? How does rifampin work? Who remembers? Anyone who remembers? How rifampin works? How?
Sir,
R.
RNA polymerase in
Correct. R for rifampin, R for RNA. So, you see, first of all, we used all the 4 drugs, all the varieties of mechanism of action. But after 2 months, first we are preventing mycolic acid formation and making it susceptible to the immune system. Secondly, we are actually preventing RNA coding, RNA leading to that protein synthesis. Okay, so these are the 2 things that should continue. So this is the continuation phase, and continuation phase can last for 4 months to 7 months. Okay, depending on how the patient is responding. So that means if you talk about say 7 months, then first initial phase of treatment was 2 months. So total number of months for treatment is 9 months. If it is like 7 plus 2, or it can be also 4 plus 2 as well. So we can call it as 6 months. Okay, so here it is written, see the range is 6 to 9 months. I think that's okay. Okay.
Yes,
All right. Now this was susceptible to TB. Now we are discussing what if they are resistant to TB. So remember that if you are like, this is what we have learned now, if the bacteria is not susceptible, then we will go for second line drug. That was the reason why second line drug got evolved. So here that is what is written. So here we have to do combination. So if you are going for second line injectable drug, you can go for amikacin, kanamycin, caprimycin or car-related drug in the initial phase. So initial phase will be injectable, and after that we can go on with levofloxacin or moxifloxacin. Okay. Now depending on specific pattern of resistance and drug susceptibility testing, another drug will be added. So initial phase there will be the injections, and then like you can go with the fluoroquinolones as well. And if you find that there are some particular specificity against some particular drug, then that like another second line drug should be provided. Now here initial phase, if it is drug resistant, then 2 months will create nothing. So here at least the initial phase should be 4 to 6 months, and then there will be a continuation phase that will be 18 to 24 months. Okay, or longer. So it is like that. Understood?
yes, sir.
Yes, sir.
All right. So once we have discussed about this thing, so there are certain things that I want you to know. That is extensively drug resistant tuberculosis, that is called as XDR-TB, and then there is its variation, that is multi drug resistant tuberculosis, that is MDR-TB. So we have MDR-TB and XDR-TB. So what is XDR-TB? Here the resistance extends beyond first line and second line drugs. That means now we have got only very few options, like the novel drugs. Except for the novel drugs, we have got no other option. Now, how is India getting recovered from here? So this is the way, that is called as a DOT. What is DOT? It is directly observed therapy. So what you have to do is, we do not want you to skip any day the medicines, but people will skip due to their job, due to their work and all. So now it is mandatory that you have to take the medicine. You have to go, just like a criminal who is on bail needs to go to the police station every day and put some signature. Similarly, here the patient needs to go to a healthcare worker, and in front of the healthcare worker the person must take the medicine. Okay, that is called as a DOT, directly observed. So when you are taking the therapy, you should be under direct observation. Clear?
Yes, sir.
So you see there is this
Yes, sir.
picture There is this picture of tuberculosis, pulmonary tuberculosis. So this is how you see that there are so many small dot radiolucencies in the chest area. Can you observe? Can you appreciate it from there? The X-ray.
Yes, sir.
Huh.
Yes, sir.
Correct. So you see, this is very easy to find out. This is called as a miliary tuberculosis. So later on in medicine we'll read, not required right now. So this tuberculosis is very easy because it's so much prominent on the chest radiograph. Okay. So anyway, so that's all about TB. I think it was a big discussion. I covered up actually pharmacology and also along with that a little bit of pathology. So everybody clear with this TB stuff?
Yes, sir.
Yes, sir.
All right.
Yes, sir.
So I think